I'm Mike McGoon. I'm a cardiologist at the Mayo Clinic. A lot of pulmonary hypertension is taken care of by pulmonologists, but I'm a cardiologist, and so I focus on the hemodynamics as well as the general clinical picture. In my practice, I devote much of my time to seeing patients with pulmonary hypertension. The balance of my time is spent in general cardiology, and also have been interested in most of my career in implanting heart rhythm devices, pacemakers and defibrillators and such. But much of my time is with pulmonary hypertension. Generally, I conduct my practice in an outpatient setting in the Mayo Clinic, which is a very big tertiary referral center in the United States. And as such, I see about 25 patients a week with pulmonary hypertension. Many of them are established patients, and part of the issue with treating patients with pulmonary hypertension is that although we are pleased with the fact that progress has been made over the last 15 years in terms of treatment and in terms of diagnosis, there's so much that remains to be done. Some of the dilemmas that I face on a daily basis are that we are seeing more and more patients who diverge from what would be considered the classical patient with pulmonary arterial hypertension, and especially from the traditional patient of what used to be called primary pulmonary hypertension, now idiopathic pulmonary hypertension. And yet we're faced with a need to try and treat these patients as well. So one problem I have is how can I apply information about medication, treatment, management that has been developed in studies dealing with very precise focus to the broader reality that I face every day. So one obstacle that I think needs to be dealt with in the research world is broadening the scope of patients who are studied in clinical research projects, studies. Another problem, of course, is even if we broaden the scope, we still have a limited number of patients, and as is a concern with physicians, with scientists, with pharma, is how can we learn more about patients and their treatment when there's only so many patients to go around and many potential avenues for looking at them. So I don't have any ready solution, unfortunately, but I think that we need to both broaden the scope and narrow the number of projects probably that can be done. I do like having heard in the last several days about open source approaches that will eventually, I hope, lead to or at least promote the idea of a consensus on how to deal with pulmonary hypertension research. I think that's an admirable goal. So in the 25 years or so that I've been treating pulmonary hypertension, we've made progress, but I feel that we're ready for a paradigm shift, if you will, in the way we are looking at it. Part of the problem is identifying the disease late in the course. And so I think more than just talking about treatment, we have to be talking about diagnostic strategies to identify patients at risk earlier in the course of their disease.